So this is your chance to ask us anything. I think we pretty much hope that anything will be about fire. But you can ask us anything. Yeah, let's go.
Hi everyone, my name is Francis. So I work at a company called Ona, and they typically implement a lot of the resources. And for every project, I have to do a file mapping of how they are using their resources. So I have a couple of questions. First one, in the ecosystem that we support, we have the concept of household first. So in fact, there's no concept of family. So we use the group resource to be able to take patients to a group and then part of that as a family. So over time, we are trying to figure out whether we are utilizing the spec or abusing the spec. So moving forward, what happens? Do we get a family resource? Do we continue abusing the spec by using the group resource? Another question that I have is, sometimes you find a lot of the partners come with an IG that they say, our country wants us to use this IG. But when you look at the IG, it doesn't also match directly what is supposed to be used. Let me say logically. For example, one use case I have is in one client came to us and told us we want to use episode of care to be able to ideally represent interactions between the clinicians and the patients. But from what I understand, you have any contact between the clinician and the patient will be an encounter. Then you have an episode of care which will be like an umbrella on top of that. So how do you deal with such scenarios, and is there flexibility given so that you don't end up in a situation where even querying the resources becomes a problem? Then the last question is on the use of codable concepts. So we have a lot of codable concepts that are being used and extensions. So one simple example I'll give you is like gender, patient gender. So you have male, female, other, and that's it. But there are people who want you to list multiple genders. But during implementation, you cannot edit the extension once it's used. So how does Fire take care of editing extensions once it's used, so that if I come today and I feel I am a man, I'll put male. If I feel tomorrow that I need to change, and then somebody convinces me back to go to be a man, there'll be a problem auditing the change in gender over time when using extension. So how do you look at solving some of these problems? So group, encounter, episode of care, and usage of extensions. Thank you.
Why not start with the hard stuff? Okay, so I came to Tanzania last year. When we did it? Late last year, I was in Tanzania. No, the first trip was last year. I think, November. Anyway, I was in Tanzania and Benjamin. You in the room, Benjamin? Yeah, oh, there you are. Benjamin got into my ear about this, and I went back to this team and I created tasks for every committee to figure this one out about families and households, and we did. So I'm going to show you what's changing in Release 6, and most of it is reasonably straightforward to bring back into Release 4. I promised Benjamin I would finish this off last night, but it's Gray's fault. I'm going to blame Gray. Is he still in the room? No, we got talking and I just talked. So with group, it's still going to be group. We're going to stick with group. But the first thing I said was, if we're going to stick with group, then anything in the spec, any resource that can deal with subject of care or actors, group has to be able to be one of them. And so when you look at release 6, you'll see that we went through and did all that. So group everywhere, so households and families. And then we took group.code. If you look in release 4, there's no codes for group.code. We actually suggested some. So we've got family, household, workplace, an exposure group. Yep. So we added them, and then we added when you list the entities in the group, you can describe how they're involved in the group. Right. And so we did this, and actually it turns out, although Benjamin and a group of other implementers with an African focus were like, come on, this is how healthcare works. It turns out that it works like that all over the world, and a whole bunch of other implementations have had the same issue and are going to use the same solution. I need to do a little bit more editorial work and write some examples. In the spec, there will be an example for household, for group, for workplace, for collective exposure, like if everybody was at a bar and there was a chemical spill at a bar. I've got to write all those examples and finish off the editorial work. And it was about 3 weeks ago that we had another big committee meeting and banged out some of the final things we were arguing about. So that settles that. And one of the things I do when I write all the examples is I'll also show what the examples look like in the R4 as well. Do I want to say anything else about that? I'll get to that in a sec. I'm just thinking about families and households. We do care about this a great deal. We've put a lot of work into getting this one nailed and happy. And in particular, there are some tricky cross-cultural issues with this one from different, materialistic cultures versus, more community-orientated cultures, and we had to navigate through those. But I'm glad to say that we've, got this one nailed. I did have to pound the table a little bit in some committees who were like, is this really important? And on that subject, it's really important to me that all of the things in the fire specification that a patient or a provider can do, the patient's primary carer can do. So I'll ask all of you for a favour. When you are looking at implementation, I think I've won in the base spec. There's nothing that a patient's primary carer can't be the provider or the receiver or the focus. But lots and lots of projects I've seen, when they write implementation guides, they don't care about the patient's primary carer, right? You can't say the patient's primary carer was the one who gave them the medication. The patient's primary carer is the one that we want to give the medication. Is wrong. So keep an eye out for that, and if you ever see that, give them the message. Patient, primary carer, whether it's family or other, matters. So that, okay, encounter and episode. You want to say something about that? Okay, I'll say something about that. Right. When we scoped out encounter can be part of another encounter. I've sat in design sessions in EHR vendors, commercial decision making, where they had 7 levels of encounter. Right? They had the overall hospital encounter, and then they had the session in the ward, and then they actually introduced a shift-based encounter, and then they had encounters with the ward round coming around, and then an encounter with the nurse encountering the patient. They tracked all of this stuff. Huh? Yeah, the oncology committee. They're all encounters of various kinds, and they were tracking all of them for billing purposes, because everything's got to be paid. And then there's an episode of care, which is like when you're not actually in an encounter, you're just caring for them over a wider period of time. But all the definitions about that are entirely circular. Like it's not an encounter because it's not an episode. It's an episode of care because it's not an encounter. What makes it not an encounter? Well, it's not an encounter. And no, we don't have any solution to this. We created those structures knowing that people will use them in all sorts of ways. And we've had some pretty fantastic arguments in the committees and in implementations about how that plays out. And this is one of those areas in the specification where, like, I tell you this, I'll probably say this a number of times today, but we have a fantasy, I have a fantasy, that one day we'll get all the decision makers about how healthcare works and we'll put them all in a football stadium and we'll surround the football stadium with guns and say, you could come out when you agree. It's not going to happen, right? So you can get a limited amount of agreement at the international level where we can get agreement that there's going to be layers of encounters and episode of care. We can't get any more agreement than that. In Australia, we could get more agreement than that because the government establishes a number of legislative and regulatory funding arrangements that actually define some of these things. That means that we can narrow it right down and end up with a lot less options. I wish I could do better than that. Sorry. Do you want to add anything to that?
No, I have usually this. I had usually the same question from different parties, and I try to move them with episode of care when it's longer than a specific encounter, but it's my own opinion. It's not written.
One of the things that we have learned, not at national level, not only at the SMART guidelines, but national level as well, is that, yeah, HL7 cannot find a solution for these things, cannot say, this is how you do it. Because it will be different for everyone. But at some point, you do need some consensus because you don't want every implementer to say, oh, but I have my implementation guide, and my implementation guide is different than yours. This happens a lot. So if you have any chance, like a national or regional affiliate, to start saying, in our scope of work, this is what we have for now agreed upon, that might help you a lot because you have an agreement. To change an agreement has some burden, and if you say everyone can come up with an opinion and we'll have to adapt, that's tricky. So if we have some affiliates, some national, regional affiliate, or some project decisions, that can help.
There is this written in the standard, so we will read it together as a church. Boundaries and relationships, 8:10. The primary difference between the episode of care and the encounter is that the encounter records the details of an activity directly relating to the patient, while the episode of care is a container that can link a series of encounters together for problems. This is what I always answer. For me, the episode of care is bigger and you have several encounters. But it's written. It's not me.
Right. But actually, what's the difference between a tracking resource and a planning resource, Diego? What's the difference between a tracking resource and a planning resource?
Planning is where you have the intent, and tracking is when you have the event.
But we track events with episode of care. So it's not clear. Sorry.
Just within clinical guidelines, we actually use episode of care to track enrollment in a particular guideline. And so that's the way that we track that a patient is enrolled. Yeah, it's bigger than an encounter, and you'll have multiple encounters within that, all related to that care related to that guideline. And so a patient can be involved in multiple guidelines by being involved in multiple episodes of care, but each one of those says this patient is currently enrolled in. That's how we use it in SMART guidelines and then CPG.
So there's some principles about how they differ, but in practice it's messy. All right, moving on to your third question. I want to start by talking about the definition of gender. We have argued about this constantly from the beginning of the project, and it's very important to pay attention to the definitions. The definition of gender is the administrative gender, the gender that the patient is considered to have for record keeping and billing and administration purposes. It is not the biological sex, the birth sex, the current social gender. It's none of those things. And our survey around the world is quite clear that male, female and other covers administrative gender. It may change if the patient has administrative reassignment. And it might change back. Well, it's pretty unusual, but it might change back. But in a lot of countries, it's fixed to male and female, including in mine. When you bill the government, you have to bill with a male or a female. The government doesn't bend on that. And so it's purely administrative. If you are providing clinical care, it's not relevant. And so then this what this note is here about it. The gender might not match the biological sex or other things. There's always other. Now, you can, and you have to pick one of these, right? That's our choice, male, female, other, unknown. And it would be typical if you were born intersex for the baby to be graded as unknown because we haven't yet decided how we're going to handle the baby. And then within the first few days, then the baby will have an assigned gender and it will move to one of the other three. Almost always male and female, but a little bit more often recently to other. And it will not be unknown anymore. Or you might just have a record where you didn't have a gender, so you have unknown. So you have to use one of those 4 codes. But you can put in an extension. All right, I was midway through typing this. So some URL, and then we can have a value of any complexity we like. And you can put whatever you want here. So you can have an exception. I might be typing with my left hand, but that's okay. So you can have a value codable concept. Okay, that just says codable concept, even if it doesn't. You can have that extension there and put whatever you want there in addition to male, female, other, and unknown. But you should not. Because remember, the definition of gender is administrative gender for billing and record keeping purposes. So the only reason you should put an extension here is if you truly have a code that is for administrative purposes that is about the patient's administrative gender. And in my experience of practice and listening to discussions about this all around the world, I have never heard of this. What I have heard is a whole spray of other things. So, HL7 published a whole implementation guide about this, how you deal with the record keeping that's associated with patients of non-binary gender. I'm not going to give you a tutorial on this IG right now, but the gender harmony specification describes how you record what the patient's birth sex was, what the patient's current biological sex is, what the patient's gender, self-identification is, so you can communicate all of those things with the patient to assure gender-appropriate care. Now, some countries won't be buying into this. Other countries are buying into this. In my country, the government's like trying to hold the implementation, not the implementation, but hold things back without making it difficult for people. So we encourage you to use these. There's one more thing missing from this that we haven't got to. I wrote a draft for it, but if you're providing medical care to someone in transition, the question you need to ask is not how do they self-identify or what biological sex were they at birth. The questions you need to ask are what bits do they still have or not have, and what hormones are they on or not. But actually it turns out that those are questions you need to ask about a lot more patients than just people in gender transition. Like, my mother-in-law's got no colon. It's a very big deal, like cancer, right? And there are people who are born congenitally without things. It's a very big deal. And so we are working towards, I wrote a draft profile for bits missing. I don't know what else to call it. And we're working towards a formal profile on that, probably in IPS, which should be ideal. And so that's the other thing to keep track of when it comes to patient gender. Do you have any follow-up questions to that? No.
The other things that are pronoun, which sometimes is asked, and preferred name. So in my country, regulation will force us to ask all this. And we, in our identifier card, national identifier card, can be male, female, or X. So our administrative sex can be X, which is other. So it fits very good in terms of this IG. Maybe the codes are different, but.
All right. Well, that was a great question to start us off with, or set of questions. Anyone else?
Yeah, thank you. My name is Fred. I had a question about clinical decision support and in specific CDS hooks. So in your experience, when you are talking about a shared decision support system, meaning that you are not just focusing, let's say, like on immunization, but you're trying to look at the more complex patient, how do you optimize your CDS hooks, or what insights do you have on that?
Well, the only, you can follow up. The only things I saw was that once you register your CDS hook service, you need to specify which hook are you talking about. What I haven't seen is some kind of prioritizing these hooks, because if you add 100 services to your hook, to one hook, then which one will you call? And we will, and I haven't seen this problem solved yet. Maybe Bryn has.
Not solved, but we've played with it. So in CDS hooks, there's the discovery API that you can use to advertise what services you actually support. So far, we haven't seen usage of that in an automated way. There's always like back-end configuration that happens. And mostly that's because you have to have institutional support to call the service, and you have to have some sort of, a BAA or, some sort of arrangement to actually access the data. So those things are not technical. They're much more, the institution is responsible for ensuring what gets called at any given integration point. And so they're typically very conservative about what they actually wire up. And in practice, the institution would prevent wiring up services that would give different answers for the same type of decision support at the same hook. We're driving towards an ecosystem where that kind of thing could be mediated, but it would require like some kind of broker where you could even detect that you had potentially conflicting advice. And there's a lot that would go into putting that system together. We've done some prototyping with it, but you'd have to, at the very start, you'd have to say, these are about the same kind of thing, right? And so, and then it gets more complex from there. But there's approaches, but nothing production so far.
And also, I think there are two levels. One level is organizational. So in this organization, country, region, whatever, these are mandatory, like they are critical. And then clinician preference. Some of them may, okay, I like this service for my specialty. We even discussed about having a CDS for which CDS call. So, because it will take the specialty, the patient characteristics. So how do you know which one to call? Because based on the clinician, the context, and the data for the patient. So, but it's not a standard. I haven't seen it. I just a wish.
So I've always assumed that the situation where the decision support systems offer conflicting advice will be extremely common and unresolvable. And the most common thing that I expect to see is the system suggesting that you prescribe a more expensive medication because there'll be better clinical outcomes, and the billing system suggesting you don't prescribe any medication at all because it won't be paid for. And that's a decision, reconciliation has to be made by the clinician. So I'm assuming that conflict is a feature of the system. When it comes to how do you display them, you do have the indicator to give some prioritization. I know I worked with a vendor where they were talking about remembering which ones the clinician interacted with. Like they would bring up the cards down the side of the screen and they would remember which ones had been used, and the more often they were used, the higher up they would display. But that's got its own problems. Self-selection, yeah. So in the end, like you fall back to some kind of system administrator as guided by whatever. But I think that we will never be able to reconcile the tension between too many warnings and not enough warnings. All right. Any other questions? Is that a warning? No, that's an error.
Yeah, so I think my question is around authoring and using structure maps for extraction. So we've been facing an issue where it's a bit of a pain to edit resources or edit properties that have arrays. Or so like the example you gave in the extension or in any other properties that have arrays, structure maps don't seem to be able to edit that. Is that a problem that has been brought forward? And is there a solution, or we're just bad at it?
Well, you haven't shown me the details yet. So I don't know. Like, in principle, you can use Firepath to cut things up or stitch things together. But I haven't seen your actual case, so I don't really know. And we can add stuff to structure map. So that's all I can say, right? What else I'll say about structure map? I wrote structure map with a partner who wrote an OMG mapping specification. It turned out very different to what I thought and very different to anything else I've ever seen. And it was really Keith's input that made it like that. But it's really, I really like the way it works. But it does mean that you have to work really hard to do some things. The advantage of the way it works is you can run it speculatively. But it doesn't mean that you can, it's ever easy. I don't know, either of you want to add more? He's got his case. He's going to write his case up and he's going to put it on chat.fire.org and we'll go through it in detail. It's just some complicated extension with I think, embedded syntax.
So, example, collected information and gender was other, and use an extension and say X, then they transition back or transition to something else. If you try to edit the X, keeps both, so you still have X and Y, but it doesn't, you don't have a way of denoting that Y is what should be used after the edit. So that's, so ideally you should be removing X because X will remain in the resource history, and the new resource should have Y. But right now, you have both in the new resource. Yeah, so that's the problem we're trying to figure out. I'm not sure why.
I think we have time for maybe one more question. And I know we had someone waiting.
Thank you. My question was around those of us who work on consumer-facing applications, addressing self-care, for example. So we have a case like in HIV programming where we have self-testing. So we'd like the patient to do the self-testing. So he is the subject, he's performing the test, and he's also interpreting the test. And then after that, if it's positive, we get a confirmatory test from a lab, for example. So the question is around how do we capture the self-testing, where the subject is also the performer and also interpreting the results.
So observation. With the subject, which is the patient, with the performer, which is also a patient, with we don't have interpreter here, but you could add an extension for interpreter if you wanted, or else, where is it? The other thing you might do is put it in a diagnostic report. And in diagnostic report, you will have subject, patient, performer, not patient. Just let me check while I'm here. No, that was where I wanted to be. Not there. It should be there. It should definitely be there for both performer and interpreter. And you can see this. You know how it's gone on before about patient's carer? There's no related person in there either. And so there's no catering for related performer. But fortunately, there's a dedicated committee member in the room who will remember this for me. No.
A key thing about Fire, I don't remember anything, I just look it up. There is a thing called value set performer function that, and since performer are many, maybe you could use, you could say the patient is the performer of the test and the performer of the interpretation. I guess that could work.
So we have work to do there. Because you should just say that the performer and the results interpreter is the patient. And this is the kind of stuff that gets me angry with because I try and keep track of all this, and here's one that I've totally overlooked. Sorry. I wish I had a better answer for you. But observation you can. Yeah. It's just a big battle because all of the people who do this, most of them are all inpatient physicians at hospitals. And they're like, patients don't interpret pathology results or diagnostic results. But of course they do in the real world. So, sorry, work to be done. I'll make sure we get onto that one. But it will be released 6. And so actually, there's something more I can say. This is a very unhappy thing, but if you want to deal with this, I don't remember what it's called. Maybe this is it. Yes, here we go. It is it. This extension here, you could use to say, because the target of the reference is not allowed, and you have a case like this. So then you would go, I'll just type this out. So that's what you might naturally have, right? But unfortunately that's illegal because patient's not allowed there. There you go. So then you can say, well, I got a performer, which is a patient, but performer is not allowed in release 4 for diagnostic report, it's not allowed to be a patient. So I'm going to tell you that I do have a performer, it's just something that you don't expect, and that's the proper way to do that. So, have we run out of time, have we?
I think we have. We just want to make sure everyone gets sufficient time for lunch and be back by 1.
Okay, no last pressing questions? Okay, we'll do one more then.
One last question.
People can go if they want to get lunch.
So maybe the last question I have, maybe for Bryn, is we have the concept of using CQL either as compiled or when using in the resources, some resources use it as inline CQL. So what's the best use case for inline CQL for resources so that you don't overburden the SDC in processing the inline CQL rather than moving it into the compiled CQL? Thank you.
The best use case for inline CQL is just when you have just a FirePath expression, right? You're just talking about things that are available in context. If you need to do anything more complex than that, like a retrieve or references of value sets, then an inline CQL is more complicated, and you're better off using a library. So that's the kind of dividing line there. If it's just accessing paths on the context that you already have, and it's just a FirePath expression, that's inline CQL. Anything beyond that, you could. Cool. Except you could just use FirePath, but then if you have a CQL engine, you have to make sure that you can pass it the FirePath. So, which you can.
All right, thanks everyone. Great questions.
Thank you, everyone.